Okay, let's unpack this. We are diving deep today into the intricate, vital, and often challenging world of intraocular tumors.
Absolutely. These conditions, they're thankfully rare, but, incredibly important.
Right, because they're often malignant and can pose a significant threat, not just to vision, but critically to a patient's life itself.
Exactly. So think of this as, well, a guided path to really mastering this information. We're aiming for that deep understanding you'd find among the elite professionals in this field, drawing directly from the source material.
Our mission, then, in this deep dive is to cover every essential detail. We want to understand not just what these tumors are, but the full picture.
The different types affecting the eye, particularly those in the uveal tract and the retina. We'll get into their pathology, how they present clinically.
The specific diagnostic methods, those
Yeah.
key investigations, and crucially, when timely referral is needed, it's about building a really robust understanding.
Precisely. And the material gives us a good starting point. The uveal tract.
Yeah, that middle vascular layer of the eye. And it's where we find the most common primary malignant tumors in adults, the malignant melanoma.
Right. And the uveal tract itself, it's made up of three parts, isn't it? The iris, the ciliary body, and the choroid. Each presents its own unique set of challenges.
So let's start right at the front with the iris, the colored part we all see. It's pretty common to see little dark brown spots there, right? Naive.
Yes, exactly. Benign collections of pigment cells, usually congenital, like a freckle, essentially.
Typically harmless then.
Typically, yes.
Yeah.
But the key thing, and this is vital, is that any documented increase in size, well, that raises suspicion. That's the trigger to watch.
Got it. Now, the source also mentions something specific you might see in children, especially before puberty hummercumitous lesions, specifically Lisch nodules,
Ah, yes, these are fascinating. They're basically pathognomonic for neurofibromatosis.
meaning if you see them, the diagnosis is pretty much made.
Essentially, yes. They appear in both eyes, usually multiple, well-defined little dome-shaped bumps, gelatinous-looking, clear, yellow, sometimes brown.
And interestingly, they correlate with age, becoming more prominent as the child gets older.
They do. But what's also interesting, as the material points out, is that their number or size doesn't necessarily track with other signs, like the cafe au lait spots, or even how severe the neurofibromatosis is overall. They're just a very specific marker.
Okay, shifting back to actual tumors of the iris, the most important one, even though it's rare, is malignant melanoma.
That's the one we really need to recognize.
And how does that usually appear?
Typically as a single isolated nodule. And the key characteristic, rapid growth. Microscopically, you see spindle-shaped or round cells, either pigmented or sometimes unpigmented, which can make it trickier.
And if it's just left untreated, what's the risk there?
It can be locally aggressive. It might penetrate the corneosclera, the outer wall of the eye, and could even perforate the globe.
So distinguishing it from, say, a granulomatous lesion is important. How do you do that?
Well, a key difference is the lack of inflammation you'd expect with a granuloma. Melanomas usually don't have those inflammatory signs. Also, the pigmentation density is often characteristic.
Although the unpigmented ones, a melanotic melanomas, would be harder then.
Much harder, yeah, because you lose that pigmentation clue. The material shows some useful images, how it can distort the pupil, what it looks like on gonioscopy in the angle, and crucially, infiltration seen on ultrasound biomicroscopy. Seeing that infiltration is vital.
And the treatment approach.
It often starts with careful, short-term observation. Repeated photography is ideal to document any change. If it demonstrably grows, then removal is needed.
How is it removed?
If it's small and localized, an iridectomy, just removing that piece of iris, might do it. But if it involves the iris root or extends into the ciliary body next door, you need a more extensive iridosclectomy.
And the outlook after removal.
Excellent, actually, provided it's completely removed.
Okay, moving a bit deeper now into the ciliary body. Melanoma here is less common than in the choroid, which we'll get to.
Right, but treatment and prognosis are broadly similar. Though surgical excision is sometimes an option for smaller tumors here, which isn't always the case deeper in the eye.
A challenge here, though, is that they can get quite big before causing symptoms, can't they?
They certainly can. Symptoms often only appear when the tumor physically displaces or distorts the lens or messes with the ciliary muscle's focusing ability.
The source highlights a really striking clinical sign to look out for those dilated anterior ciliary vessels, sentinel vessels.
Yes, that's a crucial sign. The image in the material shows it clearly. It's a strong indicator something's going on underneath, usually impairing venous drainage.
The tumor can also grow forward into the angle, right? looking like a dark crescent.
It can, yeah. Almost mimicking an iridodialysis where the iris tears away.
But you can tell the difference because you wouldn't get that red reflex shining through it with an ophthalmoscope, and there's usually no history of injury.
Exactly. And even if it's an unpigmented tumor appearing yellowish, you can often still spot vessels on its surface. You visualize these best with oblique illumination after dilating the pupil and using gonioscopy. And crucially, they block light. They're opaque to transillumination,
The material also mentions a rare ring or annular type.
which sounds even harder to diagnose, being more diffuse.
Okay, now we get to the big one, really. The choroid. Malignant melanoma of the choroid. This is the commonest primary intraocular malignant tumor in adults.
Right. Peak incidence usually 40 to 60 years old, and there's a noticeable difference in prevalence, less common in individuals of African or Asian descent compared to Caucasians.
And some key characteristics.
Yeah.
Always primary, almost always single, and unilateral, just one eye.
Usually pigmented, but unpigmented ones occur. Interestingly, the metastases are often unpigmented, regardless of the primary. The pigment is mostly melanin, maybe some blood breakdown products too. That surface appearance mottled orange and black is quite typical.
Let's really dig into the pathology, how these grow. It's fundamental to understanding them. Starts in the outer choroid layers.
Yes. Forms a mass pushing the retina inwards, initially lens shape. As it grows, it hits Bruch's membrane, that barrier layer.
And eventually breaks through it.
Exactly. That's a key moment. Once it ruptures Bruch's, the tumor cells proliferate through the gap under the retina.
Creating that classic mushroom or collar button shape, globular mass, narrow neck.
Precisely. And because the retina is only loosely attached, it detaches around the sides of the tumor. That subretinal space fills with exudative fluid.
And as it gets bigger,
The detachment spreads, nutrition to the lens can suffer, leading to cataract, and eventually it might fill the globe or even perforate the sclera, often along blood vessel pathways infiltrating the orbit.
spread to lymph nodes isn't common, but distant metastasis is.
Unfortunately, yes,
Yeah.
especially to the liver. That's a common site.
There's also that rarer flat type mentioned.
The flat malignant melanoma, yeah. Doesn't form that distinct mushroom, just infiltrates widely, thickening the choroid, causing a shallow detachment. Harder to spot sometimes.
This cell type classification seems critical for prognosis. Spindle A, spindle B, epithelioid.
Right. Spindle A are sort of slender, less aggressive looking. Spindle B are larger. But the epithelioid cells, large, round, high mitotic rate, those are considered the most malignant. And then there's the mixed type.
And the silver staining for reticulin fibers.
Yeah, that's interesting. More reticulin generally correlates with more spindle cells and slightly less aggressive behavior. It's another piece of the prognostic puzzle.
Clinically, how do these present? What does the patient notice?
Well, if it's peripheral, it can grow quite large, cause a detachment, maybe just a visual field defect, before symptoms are obvious. Sometimes the first thing is pain from secondary glaucoma.
And here's that critical point the material stresses.
Mm-hmm.
Retinal detachment with raised intraocular pressure.
Almost certainly a growth. That combination is a huge red flag.
How do you tell a tumor detachment from a simple one just by looking?
Movement is key. A simple detachment often has folds, ripples, moves with eye movements. A tumor detachment is typically rounded, fixed over the tumor's peak. The surrounding retina might look simple, though.
That orange pigment, lipofusin, is common on the surface too.
Very common. And rarely you might actually see a dual circulation tumor vessels overlaying the retinal ones. That's strong evidence.
Small, round detachments, especially in the macula or upper part of the eye.
Highly suspicious for a choroidal tumor, and for anterior ones, transillumination helps. Simple detachments are transparent, growths are opaque.
Glaucoma develops later sometimes.
Yes, multiple reasons. Tumor pushing things forward, closing the angle, cells clogging the drain, or even compressing a vortex vein.
Okay, differential diagnosis, what else could it be?
A choroidal nevus, like we mentioned for the iris, bluish patch, feathered edges, usually congenital, generally small, under 2 disc diameters, but they can become malignant. The source suggests anything over 5 disc diameters needs careful evaluation.
What about a cavernous hemangioma?
Rare, congenital, slow-growing, often near the disc. Grayish, indistinct margins can cause detachment. And sometimes localized posterior ciliaritis inflammation can mimic a small tumor.
So with these possibilities, how do you nail the diagnosis? investigations are key.
Absolutely. B-scan ultrasonography is invaluable. It delineates the detachment, shows the tumor mass. You see that classic mushroom shape, internal acoustic hollowing, choroidal excavation at the base, orbital shadowing behind it.
An A-scan gives measurements.
Yes, and characteristic patterns like rapid sound attenuation. Getting accurate measurements, height, diameter is crucial for treatment planning. The images in the source really illustrate this well, even showing extraocular extension sometimes.
Radioactive tracers, like phosphorus-32.
Right. Malignant tissue takes up more phosphate. You measure the uptake over the tumor versus a control area. Significantly higher uptake, over 80% at 48 hours, strongly suggests malignancy. Gallium-67 is another option, targeting dividing cells.
Then fluorescein angiography, looking at blood flow.
Very characteristic patterns. Often that double circulation, tumor vessels filling early, then leaking dye diffusely. The retinal vessels are seen on top. Indocyanine green angiography, ICG, can be even better for the choroidal vessels specifically. Helps differentiate from naive, which usually block fluorescence, or hemangiomas, which show distinct channels. Metastatic tumors can sometimes look similar later on, though.
So treatment, the guideline seems to be
Yeah.
pigmented lesion over 5 disc diameters.
Consider it malignant until proven otherwise. Yeah, about 7.5 millimeters.
What about very small ones?
Less than 2 millimeter thick, maybe no documented growth. Conservative management, close observation is an option, but if it grows, causes detachment, or threatens sight, treatment is needed.
And the goals.
Eradicate the tumor, save vision if possible, and keep a cosmetically acceptable eye if possible.
For those small to medium tumors, say under 10 millimeters across, up to 2 millimeter thick, brachytherapy seems key.
It is. Placing a radioactive plaque using isotopes like palladium, gold, cobalt, or commonly now, iodine-125 right on the sclera over the tumor. Delivers high-dose radiation locally over several days. Tumor regression takes months.
Other options for smaller ones.
External beam radiation, cryotherapy, laser ablation, transpupillary thermotherapy, TTT, using heat. Lots of tools in the toolbox now.
For larger tumors.
Enucleation, removing the eye, is still considered, though less frequent than it used to be. If it's spread into the orbit, then exenteration is necessary. If metastatic disease is present, it's usually enucleation plus radiation and systemic therapy.
The source mentions a concern about enucleation potentially spreading cells.
Yes, a theoretical concern that the surgical trauma might cause embolization. It's why conservative therapy, like radiation, is often preferred now if the eye still has good vision and there's no sign of scleral penetration.
Prognosis for choroidal melanoma.
Untreated, it's fatal, usually within 5 years, though metastasis can be delayed much longer. Prognosis is fairer for smaller, contained tumors, especially with less aggressive cell types. Once metastasis is detected, survival is sadly often less than a year.
We should briefly touch on secondary carcinoma to metastases to the choroid.
Right. From elsewhere, commonly breast or GI tract, often cause widespread shallow detachment, usually indicate systemic disease, so enucleation isn't the main approach.
How are they treated?
They're often very radiosensitive. Local radiotherapy works well to shrink them, preserve vision, ease pain. Systemic chemo or hormone therapy for the primary cancer can also help.
Okay, let's shift gears now to a different kind of malignancy, reticulum cell sarcoma.
Yes, this involves malignant cells that look like histiocytes, can arise from the reticuloendothelial system or sometimes the CNS, where it might be called a microglioma.
Affects older adults usually.
Typically 60s or 70s, presenting with decreased vision, floaters, sometimes photopsia flashing lights.
And the key clinical finding.
Vitreous involvement is often the big clue. You see cells floating in the vitreous that look inflammatory, but crucially, they don't respond to topical steroid treatment. That lack of response is key. There might be mild anterior inflammation, too.
What about inside the eye, on the retina?
You can get retinal or subretinal infiltrates, patchy, yellow-white, fluffy-looking areas, sometimes merging. If they hit the macula, vision loss is rapid. The vitreous haze can sometimes obscure the view completely.
Diagnosis often needs tissue.
Yes, a vitrectomy to get a sample is often required. The cells under the microscope are large, pleomorphic, with distinctive nuclear features.
And differential diagnoses.
Things like leukemic infiltrates, infections, bacterial, fungal, toxoplasmosis, CMV can look similar initially.
Why is nailing this diagnosis so important?
Because it often responds extremely well to radiation therapy. Prompt diagnosis and treatment can lead to significant, lasting vision improvement, which is not the case for many mimics.
Okay, now let's turn to tumors of the retina, and the major one here, retinoblastoma.
A tumor of developing retinal cells, essentially. Almost exclusively seen in infants and very young children. often congenital, present at birth, even if not noticed right away.
Thankfully rare, but devastating. And it can affect both eyes.
Yes, in about a quarter of cases, the fellow eye is affected independently. It might not be recognized at the same time. There's also a familial tendency in about 10% of cases, usually bilateral, inherited dominantly but with variable penetrance.
And it has a significant place in cancer genetics history, doesn't it?
It absolutely does. It was a first cancer linked to a specific genetic defect, a mutation or deletion on chromosome 13, band Q14. This region controls retinal cell division, and when it's faulty, the cells just keep dividing unchecked.
Pathologically, what are we looking at?
Small, round cells with large nuclei, resembling normal retinal cells, often areas of necrosis. And classically, you might see Flexner-Winterstein or Rosette's formations that mimic primitive rods and cones.
And it's usually multiple within the eye.
Almost invariably. When examining the other eye, you might see a larger mass with tiny satellite lesions nearby. Even microscopically, there can be scattered deposits.
Two main growth patterns described, exophytic and endophytic.
Right. Exophytic grows outwards, detaching the retina. Endophytic grows inwards into the vitreous cavity. They look different ophthalmoscopically, but it's not a fundamental biological difference. A tumor can have both elements.
The clinical course follows similar stages to melanoma, quiescent glaucomatous.
Yes. Then extraocular extension and metastasis. The quiescent stage might last 6 to 12 months.
The glaucomatous stage sounds awful, enlarged globe, proptosis, severe pain.
Which is paradoxically relieved if the tumor bursts through the sclera, often near the limbus, leading to that rapid outward growth or fungation.
Metastasis pattern is different, though. Optic nerve and brain more common?
Yes, direct extension along the optic nerve to the brain is a major route of spread. Lymph nodes near the ear and neck are common sites, too. Distant organ mets, like liver, are much rarer than in melanoma.
The most common way parents notice it, that white-yellow people reflex.
Leukochorea, yes. The amerotic cat's eye. That's the classic sign. But it can also present as a squint, a cataract, an enlarged eye, ophthalmos, pus in the front, hypopyon, or obvious proptosis.
You can often tell the growth pattern by looking inside.
Often, yes. Endophytic looks like that white cauliflower mass in the vitreous, maybe with new vessels, calcification, or seeds floating around. Exophytic presents more as an exudative retinal detachment, but the key is the retina over the tumor summit is immobile.
Secondary glaucoma is common, and sometimes hypopyon plus a turned-in eye is the first sign.
Exactly. Now, classification is important here. The older Reese and Ellsworth system.
And 5 groups, right? Based on size, location, seeding, predicting local control.
Yes, but it became limited as treatments improved. Things like anterior tumors or vitreous seeds, which were poor prognosis factors then, are often treatable now.
Which led to the international classification.
Correct. Developed in the 90s to better reflect the shift towards chemotherapy. It has groups A through E.
A is the smallest, under 3 millimeter. B is larger, or critical location, limited fluid.
C involves focal seeding, close to the tumor. D is diffuse seeding, further away.
And E is the most extensive, massive tumors, anatomical destruction, neovascular glaucoma, opaque media, invasion into nerve, choroid, sclera, orbit AC, lens touch, diffuse type, or shrinking eye.
This classification really helps guide modern therapy, especially using chemoreduction.
Prognosis. Untreated is always fatal.
Always. But with treatment for intraocular disease, survival is excellent, over 90%. If it's spread outside the eye, though, prognosis plummets to less than 10%.
Differentiating it from pseudoglioma conditions is critical.
Absolutely. Things like inflammatory deposits, toxicara infection, congenital defects like Nori disease or PHPV, or retrolental fibroplasia in preemies can all cause a white reflex.
How do you tell them apart?
Thorough, dilated exam of both eyes, often under anesthesia, and check the intraocular pressure. It's usually high in retinoblastoma, often low in pseudoglioma.
Diagnostic methods. Calcification is key.
Very key. Seen in about 75%, almost pathognomonic. CT scan is best for detecting it and checking for extension.
Ultrasound, too.
Extremely helpful. B scan shows the mass, detachment, seeds, spread. A scan gives that characteristic VY pattern with high spikes for calcification. Pseudogliomas look very different on ultrasound.
Biochemical tests.
Yeah.
Aqueous LDH.
Suggestive if elevated relative to serum, but not definitive on its own.
What if the diagnosis is uncertain but the eye is blind?
Treat it as malignant. The risk to life outweighs saving a useless eye if there's any doubt.
Okay, treatment. The algorithm in the source shows a complex picture now. Small tumors.
Local therapies are great. Cryotherapy for anterior ones, photocoagulation laser for posterior.
Yeah.
Brachytherapy radioactive plaques is also very effective. Iodine-125 plaques are commonly used now.
Radiation side effects still a concern, though.
Can be. Maculopathy, posterior lens opacities can occur later, even with plaques.
Gem reduction seems like a game changer.
It really has been. Using chemo combos like vincristine, carboplatin, eopicide shrinks tumors dramatically. This allows for less toxic local treatments, laser, cryo, plaque afterwards, often avoiding the need for external beam radiation or enucleation. And these local therapies don't seem to carry the risk of secondary cancers later.
Large tumors might still need enucleation.
Sometimes, yes, even after chemo. If enucleation is done, getting at least 10 millimeters of optic nerve and checking the cut end microscopically is vital.
And orbital spread needs exoneration. External beam radiation is less favored now.
Especially in very young children under 1 year, due to that increased risk of secondary cancers in the radiation field later on.
The success rates for chemo reduction, avoiding EBR to enucleation, look impressive for earlier stages.
Yes, very high for groups A, B, and C. Drops significantly for group D with diffuse seeding, highlighting that challenge.
Follow-up sounds incredibly important.
Absolutely critical. Need to watch for orbital recurrence for a few years. But the remaining eye needs diligent, dilated exams at regular intervals for many years throughout childhood as new tumors can arise. And family screening is vital if there's a familial link.
Wow, we've really covered a huge amount of ground there, from the uveal tract right through to the retina. Feels like we've hit that goal of a deep, comprehensive understanding.
I think so. The source provides such a detailed look at the pathology, the clinical features, the evolution of diagnostics and classification, and the sophisticated treatment strategies now available.
So pulling out the key takeaways from the source's summary, intraocular tumors arise from the uveal tract or retina. Retinoblastoma is the most common in kids, choroidal melanoma in adults.
And therapies now offer much better prognosis, with sight-saving options becoming increasingly accepted and successful.
Retinoblastoma treatment focuses on chemo reduction, followed by aggressive local therapies, reserving radiation mainly for extraocular spread.
And don't forget those metastatic deposits to the eye, usually choroid, often from breast or GI cancer. They tend to respond well to local radiotherapy.
So what does this all mean? We've really taken that deep dive, exploring the nuances of these rare but vital conditions. We've looked at specific types, how they present, the detailed diagnostic workup, including imaging and classification, and the complex treatments, aiming for that mastery level.
It's truly remarkable how distinct these conditions are, yet how the principles of diagnosis and targeted therapy have advanced across the board, especially the shift in retinoblastoma towards saving vision.
This exploration really underscores the eye's intricacy and the gravity of these conditions. We've gone from recognizing tiny spots to specific gene links, complex classifications like the International System for ARB, and advanced treatments like chemo reduction and brachytherapy. Thinking about balancing saving a life with saving sight, especially in kids, or just the skill needed to tell these apart from mimics.
It definitely raises a forward-looking question. As our understanding of tumor genetics continues to explode and imaging gets even sharper, how will these advancements further reshape things? Not just diagnosis and earlier detection, but maybe even how we classify these tumors, how we tailor treatments even more precisely. Could it fundamentally change prognosis again in ways we haven't even thought of yet?
It's a powerful thought. Even after diving this deep, realizing the field is constantly moving, there's always another layer, another question to explore.